is and today I'll be doing a presentation on ankle fracture classifications, mainly the Lauge-Hansen and Dennis-Weber classifications. So, what are ankle fractures? Ankle fractures is basically a fracture or injury to the bones and ligaments, because ligaments very often are also damaged or sprained or torn during an ankle fracture injury. And the ankle fractures consist of fracture of the bones that make up the ankle, which are the tibia, the fibula, the distal aspects of those, and the talus. And the talus usually is the talar dome or the top of the talus. And with the fibula and tibia, it's usually the lateral mal with the fibula and the medial malleolus with the tibia. And and as far as ligaments go, a lot of ligaments can also be damaged very often during the fractures, and these ligaments are usually the anterior inferior tibiofibular ligament, the deltoid ligament on the medial side, and the posterior inferior tibiofibular ligament. And also, what's important to note is the syndesmosis, which is actually what's holding a lot of the ankle mortise together, can also be damaged. And the syndesmosis is important because it provides a lot of stability to the ankle itself. The causes of ankle fractures can be twisting, rolling, falling, or direct trauma such as a car accident or a gunshot wound. These can all cause fractures in the ankle. Now, why are classifications important? Well, classifications are important because first they help us actually see or know what exactly is damaged in an ankle fracture, because ankle fractures can get messy, they're not always straightforward, and classifications help us kind of break it down and actually know what is damaged and what is not, and that in turn will help us plan on what's the best way to repair the injuries, whether it's the bones or the ligaments. So that's why classifications are important. The classifications are usually made from CT or plain radiograph images. You take the x-ray and you look at it, and then depending on what you can see on the x-ray, you can classify the ankle fracture. The two main classifications I'll be presenting today are the Danis-Weber and the Lauge-Hansen. And the Danis-Weber is actually an earlier classification, and it's mostly based on they wanted to find out, because the syndesmosis is such an important part of the stability of the ankle, they went on and they drew up this classification around the syndesmotic injury, and they came out basically the fracture, depending on the location relative to the syndesmosis, is the basis of this classification. The Lauge-Hansen on the other side is a bit of a deeper classification, and it goes more into it takes into account the position the foot was in when the trauma happened, and the force that was applied to the foot when the trauma took place. So the Danis-Weber classification, it usually determines the integrity of the syndesmosis. There are three. The Weber A classification is an infrasyndesmotic, so it happens below the level of the syndesmosis, and it happens in 20 to 25% of all ankle fractures. It's usually the most stable of the three types of fractures, and at times it would not really require, if there's no displacement and no complications, it wouldn't really require any surgical treatment. The Weber B is a fracture at the syndesmosis, and this is 60% of all ankle fractures. And this one is not as stable because it actually involves the syndesmosis itself, and it can go all the way intra-articularly into the ankle joint. And finally, there's the Weber C, which is the suprasyndesmotic fracture, and this happens at the level above the syndesmosis. And this one is also not a stable fracture, and you would need to fixate this. It's also missed a lot of the times because when you do an ankle x-ray of the ankle, sometimes this fracture is higher up on the fibula, and a lot of times it's missed and not diagnosed. but it is also an unstable fracture. Now the Dennis-Weber and the Lauge-Hansen classifications have some overlaps, and they basically classify the same type of injury. So, for example, the Weber A classification is also pretty much describing the same type of injury as a supination adduction type 1 injury for the Lauge-Hansen classification. And then the Weber B will be describing the same type of injury as the supination external rotation type 2 in Lauge-Hansen, and the Weber type C is almost equivalent to the PER4 type classification in the Lauge-Hansen. And that's because just the level of the fracture and the characteristic of the fracture is very similar depending on what both of these classifications are trying to describe. The Lauge-Hansen classifies again based on position of the foot and the force applied to the foot during the injury. And there usually can also predict a sequence of which ligament and which and where on the ankle what gave out or what broke first. So the four main types are supination external rotation, which is SER, supination adduction, SAD, pronation abduction, which is PABD, and pronation external rotation, which is PER. The SER is the most common type of injury, followed by the PER. So each classification also presents radiographical signs that distinguish one from the other. So if you see the sign on the radiograph, you could automatically tell what kind of injury this is. So for example, the SAD classification, the highlight, the sign on the radiograph you would see is a vertical fracture of the medial malleolus, and that will kind of tell you, that sets it apart from none of the other classifications have that vertical fracture line. So if you see that on the x-ray, you're assuming this is a SAD type of fracture. The SCR has a spiral fracture of the distal fibula. The PER has a high or a proximal fibular fracture, and the PABD, it has the comminuted or what's called a butterfly type of fracture on the fibula. In more detail, the supination adduction sequence is now, for the SAD sequence, we have first the anterior inferior talofibular tibiofibular sprain or a distal fibular fracture is what occurs first. So that mechanism of injury, the first thing to go is going to be the AIT ligament. Then the second following that would be the vertical medial malleolar fracture. So when you see these two things on an x-ray, you could kind of tell, what kind of injury this was and what happened based on the presentation and based on its classification. The supination external rotation sequence is as such. The first thing that goes would be the anterior inferior tibiofibular ligament. It can be sprained, which is followed by a sequence, short spiral fracture of the distal fibula, followed by posterior inferior tibiofibular ligament sprain, or actually a posterior malleolar fracture, because it depends on what gives out first. If the ligament doesn't give out and strong, then most of the time there's going to be an avulsion type of fracture. But if the ligament does tear, usually there won't be a fracture and the bone will stay in place. So that just has to do with the force of the trauma itself. And then the fourth in line to go would be the deltoid ligament sprain, or the actual medial malleolar will have a transverse fracture. The pronation abduction sequence also is as follows. First is the medial malleolar fracture or the deltoid ligament sprain. Then second, we have the anterior inferior tibiofibular ligament sprain. And the third one to get affected is that comminuted butterfly fracture that we see at the distal fibula, sorry. And then finally, we have the PER, pronation external rotation, and here first to go is the deltoid sprain or the medial malleolar fracture. whichever one happens depending on the severity or the energy, if the injury is high energy or low energy. The second to go is the anterior inferior tibiofibular ligament. Then is the high or the proximal fibular fracture, which of course a lot of times is missed, and that one correlates to the Weber C because that one also is above the syndesmosis, and at times is pretty high up on the fibula. And then lastly, in the sequence would be the posterior malleolar fracture, or the posterior inferior tibiofibular ligament sprain, which again, depending on the severity of the trauma, one will happen and one won't. So as I said, these classifications help predict what kind of injuries and what is injured, and depending on what is injured, a surgeon can draw up a plan of what needs to be fixed, what surgery needs to be performed on, because not everything needs to be surgically repaired. And for example, this is how these classifications can help us predict of what needs to be and doesn't need to be surgically repaired. And the non-surgical treatments usually involve, if it's an isolated non-displaced medial malleolus fracture, an isolated lateral malleolus fracture that's also non-displaced, and a posterior malleolar fracture that has less than 25% of the joint involvement. So then we can go and we can see which of these classifications, especially in Lauge-Hansen, will help us, can help us. So if we see like a SCR type 4, a PAP type 1, or a PER type 1, these are all showing us that there's a fracture at the medial malleolus. So once we evaluate this type of fracture and it's non-displaced, we know that we don't really need to do any surgical intervention on, and we could kind of treat this non-surgically. The predictors for surgical treatments for ankle fractures are you have to do an ORIF for the surgery, open reduction internal fixation type of surgery, and that happens with any talar displacement. If you have a bimalleolar fracture, if the posterior malleolar fracture is greater than 25% joint involvement, then what's called a Bosworth fracture, any open fractures, and any malleolar non-unions. These are all signs that you're going to have to do a surgical repair on this ankle. Final words, ankle fractures can be challenging. They could be comminuted. There could be a lot of things going on, a lot of ligament damage, a few fractures in different areas of the bone and different areas of the ankle. So the classification systems kind of help us, smooth this out and give us a good look at what is going on, what is actually injured, what do we have to repair, what do we have to work on, and what can we kind of just let alone and let be. So the classifications help us help it easier to plan for the treatment. Thank you very much for listening to this presentation.